we might move on to question time because it is a late hour. We do have a number of questions which I will read through in just one moment. Just a quick reminder to people, if you do want to ask a question, please go to the chat, click on the Q&A button and indicate who you would like your question answered, and we will start running through the questions now. So Dan, Aaron asks, how do you manage functional workup for a naive laryngopharyngeal cancer prior to any oncological treatment?
So I'm not clear whether the question means a diagnosed cancer or a suspected cancer. I think if there's a high suspicion that this person might have cancer, so red flags, then we would triage them highly for a laryngoscopy and bring them in for a formal laryngoscopy with the appropriate protection, which I detailed. If you already know that they've got a cancer, say of the pharynx or the vocal folds, then this is a category 1 urgent patient, and they should go through the normal processes of workup with appropriate protective equipment for the people that are working them up.
Okay, thanks, Dan. Next question is, and this would be to the panel, I would think. How could we deal with laryngectomy patients in teletherapy? Maybe Chris? Tricia?
Sure. I guess in terms of one of the areas that we've been looking at locally in the Gold Coast Hospital is how to manage laryngectomy patients in terms of their expectations for the services that we can offer, but also in terms of guiding them through some of the troubleshooting strategies that they have to do in terms of their voice prostheses, making sure that they're only coming into hospital if they absolutely need to have a voice prosthesis change. So we've been doing a little bit of telehealth with those patients to guide them through some of that. So some of the principles of the telehealth that Tricia talked about.
Thank you, Chris. Jasmine also asks if there's any special considerations with clients undergoing radiation therapy.
I can't think of any. So certainly, again, what we've been seeing our radiotherapy on treat patients using teletherapy, which has mostly been over the telephone actually, at the Gold Coast Hospital. And we've developed some very clear guidelines that if patients are particularly at risk of malnutrition, aspiration, based on the swallowing signs that symptoms or the signs that they're presenting with, then we'll see them as a face-to-face contact. We have also explored using some of the principles from the dysphagia telehealth practice work that's been done with the team at the Royal Brisbane Women's Hospital, and exploring using the timed water swallow test as a possible outcome measure for pre-treatment and through treatment as well, which is a measure that you can do as well as seeing them over video and getting them to be looking out for some of those signs as well. That's an option.
That's great. Still on laryngectomy, we might deal with these all in one go. This is a question for Tricia. Laryngectomy patients are having highly less immunity and risk to get affected by coronavirus. What can we suggest to them other than the usual advice? Stay home, maintain social distancing. Do you want to give any extra advice about how you could use telepractice?
I'm not sure I'm actually the right person to answer that question. So I think in terms of patients who've had a laryngectomy and using telehealth, I think our normal, there are no extra requirements there for them, but I would suggest that just as I'm talking about looking inside the mouth, we can certainly look at the stoma. We can do, talk about Stoma Care, and I'll hand over to Dan for that, using a camera in the phone rather than the laptop. So I'm afraid I don't have anything else to add.
Okay. Yeah, I mean, I think certainly for oral things and for laryngectomy care, tracheostomy care, tracheostomies are a little bit more difficult because sometimes they're clouded by the device. But getting them close to the camera to have a look, asking them to take a photo and to send it to you is another option. It depends whether you're monitoring for cancer recurrence. So if you've got a laryngectomy that's acute and healed, and you're sort of seeing them every 3 months for cancer to exclude cancer recurrence, I still think it's very reasonable to see these people in person and to put your hands on these people to feel for metastatic disease. If this is a cured patient, long-standing laryngectomy, it really depends on what the problem is. How do you communicate with them? Well, typing might be a little bit easier in that sort of situation rather than verbal communication. To this day, we haven't done that with any laryngectomy patients, but I'd be interested to see if it's easy or more difficult.
And I think just to finish that off, that's where something like Zoom, where you've got the chat on the side and you can have them typing responses, or have, if that was the case, if their prosthesis wasn't effective, or what have you, that as a secondary thing, rather than a notepad, which is what we would use face-to-face.
Thank you, panellists. We've had a question that's been voted to the top while you've been chatting, and this is a question from Dylan. Has anyone else noticed that Zoom has default noise cancellation software that makes it difficult to listen to sustained phonation? The sound tapers often can temporarily disappear. Wondering if anyone has found a fix or workaround for this other than choosing a different video app.
So I'd be happy to demonstrate a fix for this if everyone's interested. I'll share the screen. This is the best fix we've had. Let's see, share screen. We're on Zoom now. So hopefully you can see my Zoom screen there. There's a little icon here that says mute. Can you see that with my mouse over it? Can you see my Zoom screen at the moment, or not? The little menu? No? I'm not sure how let's see if I can share it another way. It's not sharing the little menu bar, but if you go down to your microphone in Zoom, there's a little arrow next to mine. And if you press on that and go to audio settings, and then move into the advanced tab, which is on the right down the bottom in mine, and you can disable the suppress persistent background noise and suppress intermittent background noise. And that will certainly help to some degree. It's not perfect, but it's okay.
And in fact, all of these audio programs across all of the platforms all have this function, and they're not actually designed to meet the needs of what we do. So it is something that we have to live with until we develop our own specialised software to meet our own needs. So there's a challenge.
Can I just comment on that?
Sure.
CoiView was designed for use with speech pathologists. And I haven't checked it, but it would be useful, and I will check it and we can attach it to the...
Well, Kath Gregory gave us she's I think she's logged off now, but she did, or maybe it's further down, but she's actually given us a review saying that they're finding it very useful. She hasn't commented on the sound quality, but she's certainly commented on the utility of the other features and notes that the patient doesn't need an account, only the therapist. So a question from Emma. Emma Wallace, thank you. Chris, thanks for a great talk. Can you comment on the risks of the first contact model for both the speech-language pathologist and the patient, particularly around misdiagnosis? What can be done to manage these?
Hi, thank you, Emma. That's kind comments. Certainly the way we run the speech pathology first contact clinic at the moment is as a parallel clinic to our ENT colleagues. So there is always ENT registrars or consultants available at the time of when we're running the clinic. So certainly in terms of any immediate risks with regards to scoping, that's managed from that perspective. In our current clinic setup, we have the ENT consultant review all of the laryngeal images and have a case discussion on the same day as the patient's seen. So every single patient will be discussed with the ENT consultant and a review of those laryngeal images. And if there's any concern, we have a very low cutoff rate. So if there's any concerns about images that we didn't quite get from the video, or any mucosal lesions, then they're brought straight back into CENT, either as a routine or an urgent case. So certainly from that perspective, and of course with the speech and language pathologists, obviously we're operating in the clinic within Australia with as an extended scope practice. So the clinicians that are involved in that clinic, that's myself and one other colleague who backfills me, have been through quite an extensive credentialing process locally within the hospital. That included observation of ENTs, them observing us and us observing them as well. And we have regular audit reporting on those cases as well. So we're covered under that local credentialing. And in terms of, I think that's pretty much it. In terms of, so that's the face-to-face model. And I guess I want to stress that the model that we've presented at the end of the talk tonight, the telehealth model, is a very, very different model. So that's not designed as a diagnostic or classification tool. It's designed as a triage tool, or as a stepwise approach, I guess, a holding tool while patients are waiting for their laryngoscopy. So we would urge anybody who's looking at those sorts of models to always be open and honest with the patient, and also the professional, also the ENT and other professionals involved about that decision-making process and the need for a laryngoscopy.
Thank you, Chris. Okay, there's a question about, Dan, can you please advise further on how changes in taste, smell are assessed and treated? Who's the most appropriate professional to refer to?
Prior to this crisis, this would be a standard ENT referral. I think that everything's changed with the potential for these people to be otherwise asymptomatic carriers. And certainly this would raise a red flag in our screening questionnaires for these people to be referred to an appropriate coronavirus testing clinic. I would ask them to, if we receive that referral, if they're screened positive on that question, I would suggest that they are presented to a clinic for formal testing for coronavirus. And if they were negative, I probably would be comfortable with 2 negative tests and sort of things hadn't settled down within a few weeks, because this is not necessarily, in my mind, an acute or urgent consultation. So if this happened acutely, they probably, or they may have the virus and need to be tested. And then down the track, we could reassess in a few weeks' time.
Thank you, Dan. Quick question, are there any digital patient outcome measures easily available online? We've developed our own called Rate My Voice, which we're in the process of taking to a next stage that has online patient reported outcome measures and data collection.
Kate, can I just chip in there? There is no research evidence-based tools as yet for telehealth. I had cause to look at this today. So the practice-derived measures, such as Kate's talking about, and I'm sure hers will become a research-derived one in due course, are as good as we've got.
Yeah, so there's an American provider of voice called Evaluate, but this is all done taking recordings on mobile phone. It's highly automated, and certainly, you know, it's very convenient. It now costs in American dollars, unfortunately for us. And the challenge we've got is that, of course, if we're recording on mobile phones and a patient's mobile phone, we run into the problem now of getting consistent recordings and whether or not they're a true representation. So the patient-reported outcome measures, there's no, everyone sort of seems to do their own thing, but so there's no commercially available one to my knowledge. Okay, question, where do we get our patients to upload their voice recording files to? We use a cloud solution for that. There's many, I won't use the name. It meets all of the legal criteria. We send them a link, they upload it, and then we share it, we listen to it. And we listen to it together and work through whether we think the voice is changing, etc. So I hope that answers the question. Does anyone have any advice on face-to-face high-intensity voice therapy? I work at a rehab hospital where we routinely see patients for LSVT. Would this be considered an AGP, an aerosol generating procedure? Great question. Thank you, Chelsea. Would any of the panel like to respond to that?
Given that they're saying running is an aerosol generating thing for heavy breathing, anything that required loud voice, I would suggest would fall into the same category as running, but that's an uninformed call.
It's very difficult. We're really not getting very clear guidelines because the research actually hasn't been done. So we are on our own to make our own hopefully informed decisions by discussion and consultation with whatever literature we can find, and managing our risk tolerances in each of our individual contexts. So I hope that's useful, but obviously, you know, high intensity voice therapy such as LSVT, the good thing about it is the microphone is further away. You can actually distance yourself. But again, I think Trish's comment is very valid here. Okay, so we have some questions here about whether we use specific apps for looking at voice quality during telehealth consultations. So there's a number of questions in regard to that. Chris, do you have any preference? Because I'm very happy to answer that.
Not specifically, no. You might be better placed to ask that.
Yeah, so certainly in my practice, we actually don't use an app because that's in some ways a bit of double jeopardy. We've already got compromised by using other people's microphones. So we train the clients to take high quality recordings using free software. So we send them instructions and links and help them. We give them a lot of support to set them up, and we ask them to use a head-mounted microphone if at all possible, so we can really control the recording. That's the plan. Most of the time it works, sometimes it doesn't, but certainly we do have quite good success in getting high quality recordings across the same equipment. And I think that's the key here. If the client can't work out how to use what we ask them to, we ask them to use something that they're very comfortable with and they can then use reliably. We may have to advise them about microphone placement to help us get the best quality recording. Now we've also had questions here about recommendations for headsets and microphones, specifically to Trisha and platforms, but I think that's probably open to all of us. But Trisha, did you want to respond to that first?
I think this follows nicely on from Kate's comments just now, you have to decide what it is you're using that microphone for. So the capacity of, any sound quality is limited by the weakest link in your system. So the microphone I'm wearing at the moment is a relatively cheap, low-end Sennheiser. I think it cost me about $80 Australian. You may find that that's adequate for many things, but it's not going to be sufficient for getting very high quality voice recordings. So it's horses for courses. In terms of teletherapy, this kind of microphone under $100 is absolutely fine. But if you're wanting to get good quality recordings, then you're going to need to follow the general specifications, rules about the dynamic range and so forth. Perhaps Kate, when I'm finished, can talk about those a little bit more. The thing that you need is what is it that you can get access to that will be reliable for you, and also what is it that your patients can get access to. So I'm reluctant to give a particular recommendation because each marketplace is going to have its own thing. Certainly a headset microphone deals with the turning away problem. As I turn my head right now, no loss in quality, and so that would be preference. If the person can't wear a headset microphone, then we can always go with the sort of neck-mounted arrangement like this, which then can allow you to have your 10-centimetre distance if that's what you require. Any other thoughts, Kate?
Yeah, look, I'd agree with you, of course, Trish. I mean, a headset microphone is way preferable. I mean, a lot of our clients want to start using their iPod microphone, and they'll often place it right in front of their mouth, and that's a really confounding factor, especially when you're trying to judge voice quality. So we just really encourage people to use the distance rule. So place the microphone to the side, keep it a relatively consistent distance if at all possible. When people just want to use the microphone in their computer, that presents a whole lot of other issues. But again, we're just trying to get data that we can compare. Now, most of the time, most of our clients are not going to want to spend very much money if they're going to actually buy a microphone. So, as Trish has mentioned, she's using a Sennheiser. We've recommended sort of cheaper brands in the past, for example, Logitech, because they've been within the financial means of the client. The general rules for microphones remain, though. In an ideal world, you want a microphone that has specifications to collect 44,100 hertz, because that's the speech range of frequency. In an ideal world, you want a microphone that has a flat response rate, so it doesn't respond differently to different frequencies. Most of the time, however, even in very highly controlled research environments, finding a microphone that does that is now quite difficult, because most microphones are designed for recording for listening pleasure. So there's a lot of manipulation of the sound at the microphone level to begin with. So I think probably, as we've said, horses for courses. You want the best equipment that the client can access, and you want them to use the same equipment across recordings and try and get them to use it in the same manner. Really acknowledging the realities of microphone to mouth distance and placement. So approximately 10 centimetres is ideal, and not in front of the mouth. Okay, so there were some questions about telehealth billing, which I'll pass on due to business and confidence. There's some questions now here. A question here about, is there any guidance on assessing a patient's suitability for further voice intervention when we can only contact them via phone call? And Chris, maybe you've got some thoughts on this?
Certainly. And I think the question referred to intensive voice therapy such as LSVT as well. I know that certainly the LSVT website does have some information and some training programs designed to assist with managing during this this period where face-to-face consults aren't so available. So certainly it would be worth checking out those websites or the LSVT website. They're very helpful. In terms of assessing a patient's suitability for voice therapy, if you don't have access to video conferencing for that patient, certainly there's a lot that you can get from a telephone conversation with a patient in terms of triaging their their main symptoms, triaging their medical history, and taking a lot of the information that might determine any urgency for any further treatment, providing any vocal health, and certainly in the first instance. So that's something that we might do with patients if we don't have, or if they don't have access to video health or video conferencing. Often patients, if you do want that video access, often smartphones are a reasonable choice as well. If the patient does have a smartphone or an iPad, it's worth suggesting that as well. Certainly, it would depend on your local health authorities' guidelines around use of smartphones for that purpose, but certainly in Queensland Health we have had authorization to use FaceTime and Microsoft Teams for video links for patients as well.
Thanks, Chris. Yeah, look, and I think one of the most important things we also need to think about when we're thinking about suitability for voice intervention, once we've actually evaluated diagnosis and case history and all those sorts of things, or possible diagnosis if we don't have an ENT diagnosis, is to literally assess responsiveness and stimulability. And we can do that. Certainly I've done that on the phone. I've asked the patient to do specific tasks with their voice and just listened and seen, you know, how did they understand the instruction, how responsive were they to actually doing what I'm asking them to do in that context. Because ultimately, if they're uncomfortable in the modality of treatment, just with a few very simple instructions like, can you say ah for as long as you can you raise your pitch, can you get louder, if they're uncomfortable with very simple things, which may not even be a formal assessment, although if telephone is all we've got, then that's what we'll try and do. So really, I mean, I think we don't have to think that we've got both hands tied behind our back here. We have our ears, and you know, we're highly trained professionals with very, very good listening and auditory perceptual skills, and I think we really need to back ourselves on that and not be frightened to use those skills in this context. They've served us very well in face-to-face interactions, but just because we can't see the client doesn't mean that we're not going to be as acute with our hearing. Okay, so moving on. Now this is probably a good question to segue to. So are there any tips on picking up subtleties of voice change or stimulability during therapy via telehealth? I'm sometimes finding it challenging to pick up clarity in those patients who I suspect are demonstrating change with therapy. However, in the absence of good sensory awareness on the patient's part, which as we well know is just therapeutically so important, I'm feeling less confident in my listening skills. So, Chris, Tricia, would you like to add anything?
Certainly, I think from the audio quality of the video, that's something that has been a challenge and has been discussed a little bit as well. And there are some suggestions for getting improved audio quality with different audio platforms or video platforms that we might be using. So Zoom does have a settings so that it doesn't cut out the background noise, which might make it a little bit easier. Certainly some of the tips that Trish and Kate have mentioned about microphone placement and also getting optimal video image as well, so getting the patient to position themselves so that you can get a little bit more of a clue in terms of stimulability and their reception of that. And I know that there are different platforms as well that might offer better audio qualities as well. I don't have so much experience with that, so maybe
Trish. Yeah, Trish.
So I wasn't going to reiterate what I'd said about audio quality and platforms, but one of the things we do often as clinicians is we use an anchor when we're making rating judgments. And so I'm wondering if you're using the same equipment for session on session, and so therefore you are able to compare, that just a brief listen before you see your client of maybe 15 to 30 seconds to anchor yourself with what they were like both before they started treatment and also what they were like in the previous session. So just this very brief listening task will provide you with an anchor against which you can make the comparison, because what the question describes is having difficulty making judgments, and we know that anchored judgments are easier than unanchored ones. So that's my 2 bobs worth.
Yeah, that's a great point, Trish. And I know in my practice, we record people every time we see them, even in telehealth interactions. And because we save those recordings, we actually compare the recording at the beginning of the session. So could we ask for a recording for the patient to do a recording every session? And if they're using the same equipment, it is much easier to hear those very small and fine changes. If they're using different equipment or they're using it in a different way, it is very difficult. So, I think Trish makes an excellent point. Thank you. Okay, so we've covered the questions about settings in Zoom and about the being sort of switched on to this original sound setting that the patient and both the clinician can choose. If people have a specific need to access that, we do have a link that we can put up on our website. So there are a couple of questions about telehealth and dysphagia. Certainly I'm aware there's some recommendations by Speech Pathology Australia in this space, and certainly some of our English colleagues have got access. Chris, are you aware of any particular body of work that could assist here?
Definitely. So there is a great body of work by Dr. Claire Burns and Professor Liz Ward. They've done a lot of research in the space of dysphagia and telehealth practice, and so they would be a great contact at the University of Queensland to ask some more questions. And I believe that they have done some great they've certainly got a training package that is available for assisting clinicians doing telehealth with dysphagia, and they've got a great protocol that they use. And I think that there's talk of that being available through the SPA website too.
That's
marvelous. Can I just add to that the next questions were about head and neck, and it's the same team who've done telehealth head and neck practice from a speech pathology perspective. So all of what Chris just said, plus head and neck.
So maybe it might be useful if we can just maybe put some links up on our website to those resources for people to explore. because I don't know, I'm not an expert in tracheostomy or laryngectomy management by any stretch of the imagination. So I think we should leave it to the experts to give advice on that one. So we've got just a couple more questions about LSVT and loud voicing. We know that loud voicing is an aerosol generating procedure. We've had one of our respondents send through a very useful reference to that. And so the question is there any advice for doing tele-LSVT with our patients? Is it evidence-based, as measuring SPL and providing good feedback might be difficult? Well, I'll hand this to Chris in the first instance, if you've got any ideas.
Certainly, I know that LSVT is very evidence-based in the way in which it's delivered as a face-to-face model. So I'm not aware of any research that's been done in the telehealth space, but I'm not an expert in that area. So again, it would be probably good to contact the LSVT advisors on that via their website. But certainly we have had some experience at the Gold Coast Hospital on delivering LSVT by telehealth, and it has been quite challenging, both from the perspective of getting the sound measures, the sound pressure level measures that are required for that LSVT, but also getting that that one-to-one interaction that often patients with Parkinson's really benefit from in the session. That's probably as much as I can comment on that at this stage. It's an interesting question.
I can add a little bit more. Deb Theodoris, who was until recently at the University of Queensland, has published a number of studies about using LSVT in telehealth settings. And one of the things I know in terms of sound pressure is having the sound pressure measured there using the client's phone and an SPL meter rather than having it measured over the computer. So it's then just having a visible sound pressure app and using that instead. So Deb Theodoris and the University of Queensland Telehealth Rehabilitation Service is where you would find the vast majority of the LSVT telehealth. Australia does lead the world in telehealth for obvious reasons.
Yeah. And look, the only thing I would add too is that, you know, we certainly in my experience, we've had fairly good success in training our patients to use the recording equipment. It's been very, very simple when we have needed to assist them to download a free app and place it in view. So we can actually see what the meter reads while they're doing it. Yeah, we've got to be a bit creative. Yes, we have to really be very supportive to get those measures in place. But certainly my experience is our clients have all been very prepared to accept the help, and because they know it's actually going to help them in the end. So that's great. All right, so just a few small ones to go. So we've got one question about the basic case history criteria we use. And I think, Chris, you may have actually spoken to that previously about what that criteria would be that would say, you know, is this person, you know, at risk or not at risk?
So certainly the model that I presented as part of my presentation probably speaks to that a little bit as well. Certainly all of the information around medical history, the patient's history around onset of the voice problem, associated history around that, are key indicators for the possible etiology behind that voice disorder or the onset. Any associated discomfort or pain would be certainly red flags for significant pathology or associated problems with the voice. Listening, being able to listen to the voice during the case history, understanding the qualities that you're listening to, the degree of breathiness, the degree of any voice breaks, any pitch breaks that you might hear within the voice as well, and understanding the main symptoms that the patient is actually describing as part of their voice. I think that's probably the primary areas that we look at.
And I think also in your model too, Chris, you looked at variability over time, if the voice was changing or not. So, you know, these key areas, isn't it, of the symptoms that they report, the medical history and their social history too, given the association with smoking and alcohol as risks of cancer. Onset and variability have always been sort of within those key questions.
And any influencing factors or triggers that are making the symptoms worse as well are very key too.
Yeah, and I know certainly in the discussions leading up to this event, you know, we've talked about sort of the other sort of more general risks, you know, sudden unexplained weight loss as being identified, and a few other, like, you know, sort of people spitting up blood or you know, yes, yeah. So these are the sort of red flag symptoms over and above what we would look for in a standard case history. All right, well, I think we're now down to our last questions, and it's over to you, I think, Professor McCabe, because we've got a couple of questions here about ultrasound. I wondered if anyone has had any experience using laryngeal ultrasound and whether there is a role for it. So I'll hand over to you. Tricia and I have done some work together on laryngeal ultrasound, but her work is far beyond my scope. So I'll hand it over to you, Trish.
So the Japanese actually lead the world in laryngeal ultrasound. And in both Japan and Italy, there's been research suggesting that radiographers, radiologists, and ear, nose, and throat surgeons may be better than chance at identifying the correct pathology from an ultrasound. One of the things you need to know about ultrasound, for those of you who haven't had the opportunity, is that to view vocal folds using an ultrasound, you have to stick the ultrasound probe under the larynx. And so you're going under the cartilage and looking at the inferior surface of the vocal folds. That is a very strange experience if you're used to the superior view. So that would be my first observation. The second observation is that the research that we've done, so Kate and I with a student and others, was a long time ago in terms of technology, although it was probably only, you know, all the research is no more than 5 years old. The technology for ultrasound is changing dramatically, and so it is now possible to get a very good, if inferior, view. The problem is we do not have standard pictures of what each of the pathologies would look like from the underneath. So there's a number of issues with laryngeal ultrasound. I think there are two significant issues we need to consider. One is this is a space that's moving very quickly. And secondly, imaging via ultrasound will, for the moment, be a screening mechanism rather than a diagnostic mechanism. There's much more work that needs to be done. That said, if you are interested in this, please contact Kate and I, because we would love to have some PhD students to examine both what the pathologies look like, and also whether we can use ultrasound in the speech pathology-led voice clinic to identify changes in the mass of the vocal folds and therefore urgent referral rather than and asymmetry and all of those other things that suggest ENT referral rather than immediate therapy. Kate, would you like to add anything to that?
Well, no, I think you've summarised it well. Obviously, it is a fast-moving space. I think there's probably going to be a much bigger role for ultrasound moving forward because the quality of the image is improving all the time, and I would absolutely repeat the call that if anyone's interested in doing some research, we've got a whole lot of ideas, and we've got some wonderful resources and supports available to do that research. It's a really fascinating and interesting space, and I think it may well become sort of a really key piece of assessment in the future. So I think that sees the end of our questions,